Next up, we have Ebony Marcelle, who is our next speaker and is the Director of Midwifery at the Community of Hope Family Health and Birth Center in Washington, D.C., which I have been lucky enough to visit and look forward to visiting next month as well. Ebony?
Hello, everyone. Yeah, after all this practice, I'm still ready to talk on mute. Sorry about that. Thank you so much for inviting me to speak. And I just feel really, really just inspired and blessed. There are a lot of amazing heavy hitters on this program. I feel very privileged to join them. Today, I'm going to talk very quickly about what RJ looks like in community health. We've had lots and lots of folks talk about reproductive justice. So I want to talk about what that looks like in my setting, which is the federally qualified health birth center, a federally qualified health center that includes the birth center in Washington, D.C. Next slide. So I would be remiss if I wouldn't talk about some of the amazing individuals out there really pushing Black maternal health to the next level. Dr. Rachel Hardiman in Minnesota really, really explicitly points out that we can't have a conversation about health disparities until we talk about racism and how that's affecting our healthcare and our systems, especially being delivered to Black birthing individuals. Next slide. So just to kind of break it down a little bit, I think it's always helpful to kind of frame it, looking at what racism looks like in maternity care with providers and patients. And so with patients, we see a lot of avoidance, distrust, they have poor experiences, experiencing a lot of microaggressions, harm, and then a lot of their care options are usually under-resourced. And what I mean by that is, you know, a lot of their tools or services are not updated, and or maybe they are utilizing the lowest cost options for resources. And then care options are usually limited and a lot more restrictive, which are not helpful, especially when maybe you are working full time, or if the place that you need to get to takes you 2 hours on public transportation. If they close or their last appointment is at 4, you're not going to make it. With providers, I typically feel like we are still struggling in medicine to perpetuate this blame narrative. We still have individuals that believe a lot of the myths about Black birth individuals. There's a lot of unchecked bias, a lot of defensiveness, stereotyping, just overall lack of cultural awareness. And the biggest thing is perpetuation of white supremacist systems. Next slide. So this was a great study done by DC Primary Care Association, a human-centered design, who got a lot of had a lot of interviews with women in the wards that I predominantly take care of with some of the worst outcomes. And as you can see, you know, they're not feeling listened to, they're not having great experiences, and it's not right. And I feel like the quotes are very impactful because, again, I feel like in medicine and in healthcare, we commonly feel like, oh, well, you know, it's not us. We're all doing the right thing, not realizing that we are absolutely causing harm to Black families. And about our foundational education, the history of this country, that still seep through into how we are delivering care today. Next slide. So this DC in particular, you know, we still have a pretty long way to go. We're working on some things. I have the privilege and opportunity to work with AZA as much as possible. We have been together for over a decade in a lot of different capacities, but we are still faced with the fact that we do not have a hospital with obstetrical services that are east of the river, on that margin that she was talking about. And that means that we don't have any high-risk services east of the river. Women are still continuing to report poor experiences at all the hospitals. You know, other compounding issues with environments, violence, homelessness, food deserts, you know, which all develops into a lot of under-resolved, unaddressed trauma with Black birthing families, and then now COVID. COVID is, definitely still, like, I don't think everything will ever go back to the way it was, and it's still impacting right now, even as we are having, some advances and some improvements. Next slide. So I work at Community of Hope, which is a started off in housing and then grew into a medical home, and has really, really grown in the last 15 years. But what makes us unique is that we are a federally qualified health center that includes a birth center, and we are one of 5 left in the country. And with the population that we're taking care of, we take care of pretty much predominantly Black birthing families, and 90% of our patients live or under 200% under the federal poverty level. Most of our patients are coming from wards 5, 7, and 8, who have the worst birthing outcomes in comparison to DC. And why that's important is, we commonly, those of us in DC, like to talk about how it's the tale of 2 cities. When you are above that margin line, that river, things look a lot different, options look a lot different, outcomes are a lot different. And so it's really, really important that we also acknowledge the level of equities just right here in small DC. Next slide. So just a little bit more about our prenatal care. Like I said, we're 1 in 5, and that means that we offer our families hospital birth and birth center birth. We definitely do not utilize our birth center as much as we should. And I feel like the important piece about the birth center is that from an equity standpoint, from a reproductive justice standpoint, it needs to remain an option, even though our volume is not high. Out of the 350 some birth centers in this country, about 10 or so accept Medicaid. We accept Medicaid. We have 10 midwives, 4 family practice docs who also participate in providing some of the prenatal care, and 1 family nurse practitioner. All of our prenatal patients are caught by the midwives, either at the hospital or the birth center. We have centering pregnancy, group care coordination. With the group care coordinators, we have perinatal care coordinators who follow our families from pregnancy to 6 months after delivery. We pre-COVID had postpartum groups. We'll be going back to that. The biggest thing that I think is really, really helpful is we have integrated behavioral health. Really, really awesome to have that element component in our care, and makes it more accessible for our families. I also really love the fact that we can continuity of the families that we maybe are with them and present for their birth. Midwives provide newborn care. We transition to our family providers, and we're still able to follow them and see them. And I really, really appreciate and love that. Next slide. So what in my mind does RJ framework look like in maternity care? We've had lots of people talk about this. But to me, I feel like it really, really starts off with acknowledgement and awareness. That, hey, things are not great, and we have a lot of room for improvement. And I think that has been one big pill to swallow for a lot of different individuals, systems, organizations, but it's true. We have a lot of punitive elements in our systems. We have to get rid of those if we feel like we're going to create a space where people are not being harmed and that they're going to want to come to. We have to make sure that whatever we are, providing our families, patient-centered, is family-centered, not because it's easier for us, not because it's easier for our systems. What do our families need? What are they asking for? Normalize shared decision making, and I commonly say this. I feel like it has become such it's documented everywhere, but I don't think people are actually doing it. So really, really do shared decision making with individuals that you're taking care of, and make it's normalized. Grow and support cultural congruency. I feel very, very lucky that We are predominantly a Black midwifery staff caring for predominantly Black birthing families. Black midwives still make up with about 6% of certified nurse midwives are Black, which is still pretty low. So really feeling lucky that not only hard to have a large amount of Black midwives, but the majority of our staff, that midwifery staff, is Black. And I think we need to look at our policies. We have a lot of policies out there that just really, really cause barriers and really, really help folks not want to engage in what we might even have to offer. Next slide. So, like I said, patient-centered care coordination. I just remember, when I was training, there's always this thought of like, we don't want to hold people's hands. Why not? Let's hold their hands. Let's hold their hands. Let's hold their shoulders. Let's hold them up. Let's lift them up. I feel like that's very ingrained in the foundation of healthcare is struggles with really trying to be supportive at times. We want innovative programming centered around families, strong collaboration with the community that you're caring for. There are a lot of ideas, programs that nobody ever talked to the community before they decided this. And I think they are commonly, communities left out of the conversation and they should not be. So making sure that we are absolutely collaborating and they are part of decisions. Prioritize continuity. Continuity is so, so important and impactful. Really trying to see we can make sure that folks are being cared for regularly by people that know them. Relationship-based care is powerful. There's lots of data that shows its impact on better outcomes. So really trying to support continuity and then constantly working on ways to address bias. Next slide. So if I wanted to dream, and I constantly believe that when you say things, you also speak to the universe and make it happen. I'm going to say no disparities. I'm going to go big. Access and quality wouldn't be a question. So it shouldn't be that when you enter the district that you get a total different type of care in one ward than you do in a different ward. Options for out of hospital birth, meaning that, hey, we are licensing and supporting all pathways of midwifery, CPMs, CMs, LMs, CNMs, everybody, that there are hospitals and birth center options that are paid for through insurance companies. Midwifery aligns with physician colleagues. This is really important. We do have folks who are not 100% eligible for midwifery care. For us, what that looks like is I get to co-manage my patient who's severely preeclamptic with my physician colleague. And it is so impactful to that birthing individual to maintain midwifery care. So, I use this a lot when I'm teaching, but I have had, someone who's had IV push medication, on MAG, super, crazy blood pressures, but we were able to have a beautiful hands and knees delivery, unmedicated, and with her midwife, she had seen for her prenatal care. So really, really wanting to shout out strong collaborations with physician colleagues and also maternal fetal medicine. We do a lot of management with our MFMs in the district. It's also important, let me not forget, it's also important for our out-of-hospital community birthers to have safe places and spaces and collaboration for transfer. We talked a lot about cultural congruency, but definitely want more Black midwives, but we need more Black social workers, lactation, doulas, just more representation in a lot of these spaces. And then what I mean by lactation and doula as a standard of care, that it's not a question if it's going to be covered by your insurance. It just is. You're not having to go through a bunch of hurdles, or maybe, it's only going to cover that one person who's like 15 miles away because they're cheaper. just that it's just a standard that when you have a baby, you know that there's services that you can receive and it's not an issue. Um, Next slide. And then more dreams, infertility. I think there are a lot of families, and I can speak as someone who struggled with infertility and quote unquote educated with a decent income, still struggle trying to get coverage. Actually, matter of fact, let's be honest, there is no coverage for infertility, and that's just me. But we need to have conversations about supporting low-income families who want to grow their family. Um, Ongoing bias training, not I went to a class for 2 hours and now I'm less racist. It does not work. These need to be things that are ongoing, consistent, regular. And then I want to have a world where Black birthing families have beautiful, transformative births and feel seen and feel heard and feel loved.